Morning, students. I'm here to talk to you today about the content that you will find in Chapter 22. After the neonate is born, our care is focused primarily on assessing and stabilization of the baby. We see that the baby has several priorities in order for them to establish life outside of the uterus. Some of those uh, priorities include replacing the lung fluid with oxygen to breathe, trying to keep himself or herself warm, opening pulmonary circulation and closing shunts, redistribution of blood volume, and finally detoxifying and disposing of waste. When we look at the respiratory system, of all the changes that are important, the newborn must be able to breathe on his own. When we look at the newborn respiratory rate, we find it varies with state of awarenesses, just as the adult does. So if we have a baby that's crying, of course the rate is going to be higher, and if we have a baby that's sleeping, that rate is going to be lower. Commonly, the respirations are shallow and irregular. Periods of apnea less than 20 seconds is acceptable, but observation should still be maintained. We're looking at respirations normally to be around 40 to 60. Prior to delivery, the lungs are filled with fluid that must be removed and replaced with oxygen. If this evacuation is incomplete, TTN may occur. Now, what is TTN? TTN is a common transitional problem, as its name indicates. It stands for transient tachypnea of the newborn. It is wise to keep a blue bulb in the crib just in case these babies become just a little bit spitty because there is mucus still in the stomach. Because of residual fluid in the lungs, slight crackles may occur. The newborn's first breath is initiated by a sequence of sensory, chemical, thermal, and cardiopulmonary changes, including shunts closing. It's important to note that if the mother received narcotics in labor or shortly before the delivery, the newborn may have depressed respirations. Cardinal signs the newborn is having trouble breathing are grunting, nasal flaring, and sternal retractions. Treatment is Narcan. Let's talk a moment about surfactant. Surfactant is a phospholipid protein that allows the alveoli to expand and contract during respiration. It is a substance that increases as the neonate matures in utero. Hence, neonates born prematurely have lower levels of surfactant, making breathing on their own more difficult. If a mom is suspected to be at risk for a preterm birth, she is given betamethasone as an IM injection. It's a corticosteroid and it increases surfactant production. Surfactant can also be administered to premature infants after they are born. Cardiovascular. The cardiovascular system changes significantly at birth. If you recall, before birth, the neonate's cardiovascular system received oxygenated blood by way of one vein, and waste products were disposed of by way of two arteries. After birth, that process will convert to the adult circulatory system that we are familiar with now. Shunts are vessels that assist the bypassing of some fetal organs while in utero. The foraminal valley, the ductus arteriosus, and the ductus venosus. At birth, these shunts are no longer needed, so they should close. Most usually close by 24 hours, but if they don't, you may hear something called a murmur. At that time, the doctor may order, we need to get a blood pressure on all four extremities and possibly order an echo. Murmurs are often non-pathological and transient. and each murmur has a different sound to it that assists with the diagnosis. And murmurs are caused from shunts that do not close completely at birth. Skin color is another important sign that a newborn is having difficulty adjusting to life outside the womb. During crying, it is not uncommon to see newborns become acrocyanotic. What does that mean? Acrocyanosis is blue hands and feet. And that is acceptable to see in the first 24 hours. It does maintain that we still need to observe. Unacceptable findings includes any cyanosis while sleeping, or any circummoral, which is blue around the mouth, or central cyanosis. Also, jaundice in the first 24 hours is not acceptable. The hematological system. Fetal circulation is less efficient in oxygenation, and the fetal RBCs have a shorter lifespan. So there is a need for a greater number of fetal RBCs to oxygenate the fetus while in utero. After birth, these extra cells are no longer needed and therefore broken down. A byproduct of that process is a substance called bilirubin and is yellow in color. Bilirubin is sent to the liver for conjugation and disposal through urine and stool. Often the newborn liver is not quite mature enough to process the excess bilirubin, and these bili levels will increase in newborn serum levels. We'll talk about this again in later chapters. Two types of maternal-fetal incompatibility, blood incompatibility, occurs. The first one is called Rh incompatibility. The only way that this occurs is if the mom is Rh negative and the newborn or the fetus is Rh positive. If that occurs after the birth, the mother is given an injection of Rogam or Roflac. If not given, and there was a transfer of fetal and maternal cells with that pregnancy, mom is said to be isoimmunized. That means that her body has the antibodies to fight off a future Rh positive fetus if she were to become pregnant again. At birth, the newborn of a woman with an Rh negative blood will have a sample of the cord blood sent to the lab. Two things that they're going to be testing. The first is they're going to test the baby's blood type to find out what kind of blood the baby has. And the second thing is it's called a Coombs test. If the Coombs comes back positive, that means that has been or may have been a maternal and fetal exchange of cells during pregnancy, and we need to watch for jaundice in the baby. The second type of blood incompatibility, I apologize, is if only occurs if the mother is O positive and the baby is A, B, or A and B. Again, this is a lesser issue than the Rh incompatibility, but we need to monitor the baby for jaundice in this case as well. Thermogenic system, thermoregulation. Hypothermia can be pathological in newborns. Next to stabilizing respiration and circulation, establishing thermoregulation is primary for the neonate. Goal is to establish what's called a neutral thermal environment. Types of heat loss are listed on page 561. Hypothermia in newborns can be very common due to immature temperature regulating centers and secondary to vessels being close to the skin. The most common reason for hypothermia is failure to drive. Hypothermia can also be associated with a variety of other issues like sepsis or hypoglycemia. Hypoglycemia and hypothermia pretty much go hand in hand. And the reason is if a baby is cold, hypothermia, they use they use their glucose stores to warm themselves, which causes hypoglycemia. Newborns are not able to shiver to warm themselves and must use increased muscle activity or glucose stores. This is called non-shivering thermogenesis. The result is O2 consumption leading to increased respirations that result in metabolic acidosis. Hyperthermia is less common, usually appears due to environmental issues. Mom's been holding the baby for a long time, skin to skin, and perhaps mom's got a bit of fever. More uncommon, but possibly due to sepsis also. For minor treatment, first recheck for correct probe placement. If still cold, place the newborn on the mom's chest, skin to skin with a warm blanket. This is called kangaroo care, and it should hold for 30 minutes. Then recheck the temp. If the temp is still low, place the baby under the warmer, notify the healthcare provider, and check the glucose level. Okay, let's talk a little bit about temperature instability, or continue to talk about temperature instability and something called cold stress. You can find this information on page 561 and 562. Cold stress imposes metabolic and physiological demands on all infants, regardless of gestational age and condition. We've all heard of babies dying of exposure, not uh, from dehydration, but from exposure. I like this slide. It does a really good job of explaining a complicated concept in not so complicated terms. Some of the signs and symptoms that we see of a baby that's experiencing cold stress are jitteriness, lethargy, a weak cry, hypotonia, temperature instability, poor feeding, and poor feeding. Just a few. Prevention. The first prevention and primary importance is dry the baby and remove all the wet clothing. Keep the baby away from drafts and place the infant in a pre-warmed radiant warmer. The renal system. When we're looking at the baby's renal system, we again, excuse me, counting the number of voids gives us a real good indication on whether or not our kidneys are working. And it's based largely on fluid intake. Well, that's kind of difficult for newborns because when they come out, they are awake for one good feeding, about an hour or so, and then most of them anyway, promptly fall asleep. So it's real difficult to get a lot of voids. What we like to see is a one void in the first 24 hours and two voids in the next. Newborns are unable to concentrate their urine, so usually what you're going to see is straw colored. We're going to continue to assess for dehydration, though, looking for the same things as we look for in adults, like dry mucous membranes and poor turgor. One main difference is we're also going to look at the fontanelles. We want the fontanelles to be level. If they are sunken, or if the eyes are sunken, that can be an indicator of dehydration. Also in males, it is important to assess malposition of the male meatus. The meatus should be in the center. Malalignment can be hypospadias or epispadias. The GI system. At birth, the stomach has quite a bit of mucus in it, and as I mentioned earlier, babies can be gaggy in the first 24 hours. That blue bulb in the crib is very helpful because that can be distressing for parents when they see their baby gagging, gagging, gagging. If we are able to calm that situation down and show them how to use that blue bulb, it's helpful for them. Nutritional intake, also as mentioned earlier, we're going to get one good feeding in at birth. That's common. There's always exceptions to the rules. That there are some babies that will eat more, and hopefully this is the case. Newborns are able to process proteins and simple carbs. But babies have to learn a coordinated mechanism called suck, swallow, breathe in order to take in nourishment. This sucking reflex should be checked at birth by inserting a gloved finger into the neonate's mouth to elicit the sucking reflex. This process also checks for intact, soft and hard palate. Regurgitation is often an issue due to an immature cardiac sphincter. This sphincter does not close and allows the food to move back into the esophagus. Regurgitation can also be caused by overfeeding, typically seen in formula-fed babies. Your textbook says that a newborn stomach has a maximum capacity of 30 cc's in the first day and 90 cc's by day 3. I will tell you, in my practice, those numbers seem to be a bit high. Neonatal stool. At birth, the lower intestine is filled with meconium. This thick, tarry green-black substance should have the first passing within the first 24 hours. So what are some problems? A problem could include inspection and not finding an anus. That's called an imperforate anus. Or if an infant doesn't pass a meconium stool in the first 24 hours, that's indicative of a meconium ileus, and it can be connected to cystic fibrosis. The hepatic system. The newborn hepatic system basically has 4 functions. The liver is the source of iron stores occurring in utero. It also plays a part in carbohydrate metabolism, bilirubin conjugation, as mentioned before, and coagulation. At birth, the newborn will have decreased glucose levels because the maternal glucose supply stops when the cord is cut. And as we've talked about just a couple of slides ago, bilirubin conjugation, the bilirubin, the byproduct for hemolysis, needs to be conjugated or prepared for disposal. Unconjugated bilirubin, which is also called indirect, is insoluble and bound to albumin. This is the bilirubin that causes the skin and sclera to turn yellow. Conjugated bilirubin is soluble and excreted in bile, urine, and stool. We will talk again about hyperbilirubinemia. Vitamin K assists with coagulation, and it must be administered IM since PO uptake requires normal flora and enzymes that are not present in the stomach at birth. Hypoglycemia. Normal glucose levels in the newborn should be greater than 40 in the first 72 hours and greater than 45 after 3 days old. At birth, these levels can decrease as low as 30 for the first hour or so. That's very low, and we need to keep a good eye on that. It is important to put the baby to the breast if breastfeeding during the recovery period, and or feed them if that level drops to 30. Feeding does help to stabilize at 40 to 60. Testing newborns for glucose level is pretty much dictated by the individual institution, but common signs to look for hypoglycemia. The number 1 sign is temperature instability, followed by a very close second of jitteriness. Lethargy, hypotonia is seen, and poor feeding, which makes it difficult. If you've got a poor feeder because their glucose is low, the only way to get the glucose up is to feed them, so it makes it kind of a challenge. Infants at high risk for hypoglycemia are infants of diabetic mothers, and that doesn't necessarily mean that they're small. LGA babies, you could have a 10-pound baby that's 35 weeks because they were born to a diabetic mother. They have all these extra glucose stores on board from mom, which made them bigger, but they are not ready to breathe on their own. We call them gentle giants. So LGA babies, SGA babies, a stressed neonate, a high risk baby is also one that is not eating well, and of course the preterm and postterm babies. The treatments, as mentioned, is always to feed them. Repeat the glucose test, which should be a heel stick initially, 30 minutes to an hour after the feeding. If we find that it is still low, most institutions will mandate a lab draw at that point in time because they are more accurate, and IV dextrose. Integumentary system. I think this slide outlines some of the issues or some of the common integumentary items that we could see in newborns, and I think they're very important for you to know. Uh, Refer back to pages 568 and 569. Wanted to talk a little bit about palmar creases. A normal palmar crease is seen on the left side of this slide. You can see there's a couple of creases. On the right side, we see simian creases, or asimian crease, which is literally one crease that goes from one side to the left side of the palm. If these are noted to be on the hands of a baby, it can be indicative of a chromosomal defect and needs. The reproductive system. At the time of birth, the mother will have increased levels of estrogen that is transferred to the fetus. These increased levels can cause a vaginal mucoid discharge, sometimes mixed with spotty blood, which is called pseudomenses. In both sexes, it can cause increased breast tissue. For the reproductive system on a female baby, we are looking for the majora to cover the minora. That's a sign of maturity. And keep in mind that vaginal tags are quite common. In the males, 90% of term males should have descended testes. An increased rugae is a sign of maturity. Hydroceles can be seen. It's an accumulation of fluid in the scrotal sac. Most of them are self-limited and will absorb in the first year of life. Keep in mind also that foreskin is non-retractable until about 3 or 4 months old. Sutures hold that in place. Let's take a look at the immune system. Immunity is provided for approximately 3 months through the circulating IgG antibodies. Protection is provided by passive immunity via the placenta. Breastfeeding provides infants with IgA antibodies in the intestinal tract, which neutralizes bacteria. Hand washing is always advised both for staff and visitors. Newborns are poor at fighting off infection. What are some of the signs of infection? A primary sign is temperature instability. Again, babies not being able to keep themselves warm. Second to that is hypoglycemia, respiratory distress, lethargy, and poor feeding. Natural barriers are not present until about 3 to 4 weeks of life. WBCs should be seen at about 18,000 at birth and should be at 18,000 at birth. They're around 23 to 24,000. The first day after birth, they decrease and rapidly stabilize at 12,000. Hemoglobin should be 14 to 24, and hematocrit should be 44 to 46 to 64. higher than adults. Skeletal system. At birth, the neonate has more cartilage than bone. The head is clearly a quarter of all total body. Growth is called cephalocaudal, which means head to toe. And we see fontanelles. There's an anterior fontanelle, which is diamond shaped, and a posterior fontanelle, which is triangle. As mentioned before, a good assessment includes palpating the fontanelles for fullness or bulging. They should be level. There are bony plates of the head that are not fused, but held together by what's called sutures. It's a rubbery kind of substance that holds those plates together until until the head stops growing. Head lag is okay to be seen. Caput encephaloma is a common birth injury, and we'll talk about them later in a subsequent chapter. The extremities should be symmetrical and of equal length. Polydactyly is extra digits, and syndactyly is fused digits. The Ortolani maneuver is a test that checks for hip displacement, and that's going to be discussed in the next slide. The spine should be flexible with no openings. Of particular importance would be a finding of a pilonidal dimple at the base of the tailbone. It may or may not include a tuft of hair, and this should be reported to the healthcare. Okay, developmental dysplasia. It's an abnormality of the developing hip. The femoral head has an abnormal relationship with the acetabulum. It's associated with breech presentations. It may have some genetic factors, and it's more commonly seen in females. And I think that's due because it's associated with greater susceptibility to maternal pregnancy hormones. There is a maternal hormone that increases just before birth. It's called relaxin, and it helps to loosen the ligaments so that the bones can separate and the babies can be born. Assessment for developmental dysplasia includes laxity of the ligaments, unequal gluteal folds, and a positive ortolanis, an unequal buttock and thigh skin folds. Treatment includes a Pavlik harness, and pretty much the babies need to keep that on 24/7. It is measured and placed specifically by an orthopedic doctor, so those numbers need to be held in place. Muscular system. One of the things that we are looking at as a strong sign of maturity is if the baby is resistant to pulling legs and arms. Babies should be flexed. Other than that, we should note their symmetry of movement. We do not want them to be a rag doll. As mentioned before, the head should be 1 to 2 centimeters larger than the chest. Glucose and oxygen are needed for brain development, and normal tremors are expected, especially a quivering chin with crying. We've all seen those little babies that are crying just so hard their little chins are quivering. Hands and feet can tremor on occasion, but never while sleeping or beyond 1 month of life. Non-expected tremors could be secondary to hypoglycemia or drug withdrawal. The last slide talks about some reflexes that I think are important to know. They're classified under behavioral characteristics. The book does an excellent job, and we want to make sure that we know at least these real well, because absence of these could be a neural problem. So we want, or could be a problem of birth trauma. So please be careful to take a look at these. I'm hoping that this was helpful and everybody enjoy the rest of your day.